Friday afternoon and go over some of the questions, but we have time now. And as I just said, there are no stupid questions now. So think about anything that you didn't understand well for my lectures or nephrology in general, or even medicine that I can be helpful. Anything that you didn't get it really, either nephrotic syndrome, acid base problem, kidney stones, hyponatremia, anything that you would say, well, because it is a lot of information. Each one of those topics, you can write books about them. So putting like all of those information, all of that information in just a couple of hours, I think is just mind blowing if you guys can follow all of that information. But any question that you say, well, I really don't understand this. No? Very good. You guys are smarter than I am. All right, so let's talk about the last part of the nephrology lecture, which would be nephritic syndrome. So, in contrast to nephrotic syndrome, that would be somebody who comes with what? Let me ask you. So, nephrotic syndrome, what makes me think that somebody has nephrotic syndrome? Not nephritic, but nephrotic. Nephrotic, yes. No, they don't have blood. No. Very good. They have proteinuria more than 3.5 grams a day. What else? Let me ask you. Yes. No blood in the urine. Okay. Or a small amount. Very good. What else? Yes. Low amounts of albumin in the blood, hypoalbuminemia. And what else? The high lipids. But one of the first things, as soon as I see them when I walk on the street, huh? Edema. Yeah, they have edema. They have a huge, and that's the main reason they come and see you because they say, well, doc, I don't know what's happening to me. My legs are so big now, or I have fluid under my eyes. I don't know what's going on. In contrast to that patient, this patient comes with a different set of problems. They have protein in the urine, but maybe not nephrotic range proteinuria, but they have blood in the urine, which is called hematuria. They have abnormal kidney function usually, which means decreased GFR or high creatinine, and they have high blood pressure. So they have blood in the urine, oliguria if they are really sick. What does oliguria mean? Okay. Or what is anuria? No urine. Very good. Not everybody has all of those things. Many people, they have blood in the urine, could be high blood pressure, and could be worsening kidney function. So if somebody comes with hematuria, hypertension, and possibly worsening kidney function, that person had nephritic syndrome. And then we have to figure out what they have. These are the difference between nephrotic syndrome and nephritic syndrome. Proteinuria for nephrotic syndrome, low albumin, high lipid, edema. They have hypercoagulable state, and there's like leakage of the vessels. Whereas for nephritic syndrome, they have hematuria, hypertension, they could have renal failure, oliguria, and many of them, they have systemic diseases. Okay, so hematuria means that you have blood in the urine, usually more than 2 RBCs per high field that you look at them. They gonna be like many, if in board exam or patient, they have 50, 100, 200 RBCs. And the differential diagnosis for us would be this set of diseases. More importantly, for our purposes, would be IgA nephropathy and post-strep glomerulonephritis. IgA nephropathy and post-strep glomerulonephritis. Membranoproliferative GN also is an important part. It's a little bit, I don't think that they will ask you questions, but they may ask you about lupus and vasculitis. I'm going to leave a little bit of vasculitis to rheumatology classes because they will go over that again. But I'm going to briefly talk about it about lupus and vasculitis as systemic diseases that can give you nephritic syndrome, like diabetes for nephrotic syndrome. There is a disease called amyloidosis. You guys have heard about amyloidosis? You can get nephrotic syndrome with amyloidosis as well. And the interesting thing is that there are few cases that you have kidney problems with enlarged kidneys. Usually, when the kidney is sick, they get small, except for two diseases, diabetes and amyloid. They have enlarged kidneys. So when they say, well, somebody comes with enlarged kidneys and they have kidney problems, think about diabetes or amyloidosis for those patients. So how do we make the differential diagnosis for IgA nephropathy, post-strep, or membranoproliferative? So IgA nephropathy, it happens in Caucasian and in Orientals. In Japan and China, they have a huge incidence of IgA nephropathy, especially in Japan. So if they ask you, a Japanese guy comes to you with nephritic syndrome or hematuria, think about IgA nephropathy. Usually they give you some hints on what's going on. And IgA nephropathy means that they have deposits of IgA, obviously, IgA nephropathy. They have deposits of IgA, and the deposits are around the mesangium. So when they look at it, then they stain for different immunoglobulins, and they see this is IgA. The deposits here are IgA. They use IgG, IgA, different types, and say which one are those deposits. And in this case, they would be IgA nephropathy. So they have IgA deposits in the mesangium, and they come with hematuria. This is a very common disease, probably one of the most common causes of kidney diseases, definitely by far the most common cause of nephritic syndrome. Some of the new advances, they figured out not too long ago that what happens to this disease, there is something called four-hit theory for developing IgA nephropathy. Most people, they have some sort of genetic background to IgA nephropathy, but then they have very elevated levels of what is called a galactose deficient IgA1. Galactose deficient IgA1. They develop antibodies against that antigen. This antigen and antibody, they bind to each other. They get deposited around mesangial cell, and you get IgA nephropathy. So it's something that new, like PLA2R that I talked about, membranous nephropathy. The antigen is known now. The antigen is known for IgA nephropathy, and the antigen is a galactose deficient IgA1. Okay? All right. In your board exam, and that's very common, how to differentiate post-strep versus IgA nephropathy, because commonly both of them they have infections before having hematuria. The difference is with IgA, they say somebody has some sort of infection, upper respiratory infection, but 2, 3 days later they have hematuria. If that happens, is IgA. If they say 2, 3 weeks later, that could be post-strep GN. 2, 3 days later, IgA nephropathy. They get infection that triggers the immune deposits and hematuria for them. That's a very typical question. That's something that for many, many decades, they ask the same question. So the deposit would be a kidney biopsy, and the renal survival depends on what is the decrease in GFR and how much protein they have. The treatment, even for us, we don't know exactly what the treatment is. So they are not going to ask you any question about IgA nephropathy. I put some of the important topics later on when you guys get into clinical rotation. You can come back and take a look at this. Now, post-strep is somebody who got pharyngitis, right? And usually nothing happens to them, but in minority of cases, 2, 3 weeks later, they develop hematuria. That could be post-strep GN. The second hint is that they have elevated ASO, anti-streptolysin O antibody that we check on every patient. They could have anti-DNase B antibody, and they have low complement 3. That means that they get consumed. Complement gets consumed in this patient. So they usually gives you some hints of somebody who had pharyngitis, developed hematuria 2, 3 weeks later. In order for us to follow those patients, we check ASO antibodies, we check the anti-DNase B antibody, and usually they have low complement C3. If they case something like this, they give you a case. This patient has post-strep GN. The other thing they may ask you would be this deposit that you can see on top. The first one with membranous, they call spike shapes. Here they call it hump shape. You can see up there it's a DDD. These are both are subepithelial deposit, which means that on top they have podocyte, their epithelial cell. Under the podocyte, you have this deposit. Hump shape, think about a strap. If they say spike, think about membranous. Okay, if you guys know up to here, I think it's good enough for lecture today. But I'm going to talk a little bit about more medicine. There are two systemic diseases that could cause hematuria and nephritic syndrome. These are common diseases. Lupus, ANCA is not that common, but lupus is not uncommon at least. You guys had any lecture on lupus or ANCA vasculitis? Okay, so that makes my job much easier. So with lupus, which is much higher incidence in Black and Hispanics, and probably some Asian countries than whites, and people can come with proteinuria with or without blood in the urine. The diagnosis is based on making the diagnosis of double-stranded DNA or anti-DNA antibodies that they may have. For kidney problem, you don't have to learn all of those things. We do a kidney biopsy and we figure out, well, what's happening to the patient, because the treatment is a little bit different. Class 1, they have almost normal or minimal changes. Class 2, they have mesangial proliferative lesion. You guys don't have, the only thing you guys have to know, class 5, they have membranous. So if you have somebody with membranous GN, they may have lupus. Okay, that's something to remember. One of the diseases would be when you have somebody with membranous, think about they could have lupus nephritis. Well, they could have membranoproliferative as well, but type 5 of lupus is membranous alone. This is the type of pictures that I don't think they ask you anything about that. The management also depends on we give them immune suppression because it's immune disease. We bring down their immune system. You guys don't have to learn any of those. Okay, ANCA or vasculitis, the only thing I want you guys to remember, there are different types of vasculitis in the kidneys. Granulomatosis with polyangiitis, we used to call it Wegener disease, microscopic polyangiitis, Churg-Strauss syndrome, and renal limited vasculitis. Usually you do have this kind of picture that you see fibrin deposit in the kidneys. You don't have to know any of those things. The only thing you guys have to know is ANCA. When you do the biopsy, okay, you see vasculitis, which is fibrin. They are not going to ask you that. But depending on what type of ANCA you have, positive or negative, you can have ANCA vasculitis. ANCA could be GPA or MPA positive, okay? And GPA, you can have PR3, and MPA could have more limited type of vasculitis. So depending on what type of, whether you have PR3 positive or not, that's very important. PR3 positive is called Wegener syndrome. PR3 positive vasculitis is called Wegener syndrome. That's also something that people used to lose their kidney function. Nowadays, we do have treatment for that. That's something to remember for now. And the only way we would know it is to have ANCA positive. We order the test and see whether it's PR3 or MPO positive. I think there's some new treatment. I don't think they're going to ask you anything about new treatment of ANCA for the time being. Maybe in a year or two, they will start asking questions about the use of complement inhibitors for ANCA vasculitis. But just because even in clinic, we don't use it as much, I don't think they're going to ask you in your board exam for now. I'm going to stop here and see whether you guys have any question about nephrotic syndrome, nephritic syndrome, any kidney disease in general. No? Very good. No? Yes. Yeah. Yeah. Well, there is no magic bullet that you remember all of those things. But whatever you guys are learning here, you're going to hear over and over and over and over during your clinical rotation, during your residency, during your internship, if you go to fellowship. And then you're going to be seeing so many patients that things that now they are very, very complicated and it's hard to remember. It just you learn it just by repetition and repetition. In fact, after a while, as I said before, it gets kind of boring because you already know when you're just looking at the labs of the patient. In my case and many other people, you already know what you want to do with your patient just by looking at the labs. So for now, you just have to memorize a little bit and go over it with other colleagues. I think that's the best way to remember. Obviously, medicine in general is a little bit of learning everything. My personal experience has been that although we have to study for the board and all of those things important, this is a way of living. This is a technique and a science that you're going to be using it to take care of your patient. So you just don't want to have good notes. Every day you want to learn something. Just imagine you are going to a bakery and every day they teach you how to make this pastry. It's not just you just want to write it down and just learn it later on. Every day you want to learn and go and practice it and try it again by repeating among yourselves, by studying and reading books about it. And each time you retain more and more about, well, how do you approach? And after a while, you're going to have your own way of studying. In other ways, I think you guys have to not just think about board exam all the time and how to pass board, even though it's important, but try to learn in a way that even if you lose your notes, you remember enough at least to pass your board exam. Because it's very hard to just to study for board. You just have to have the knowledge. And the questions are such that if you just study, it's very hard to pass. You really have to know, you have to have the knowledge in order to do well. And studying medicine is not that difficult. It's not like math or physics. Maybe nephrology is a little bit more complicated, just the way the rationale. But if you do it here, if you read it few times, in general, I think you're gonna do well. You cannot not study. You know that even if I go and do board of nephrology, I have to study. I cannot just go, well, I know enough. That's very hard to do. You have to study. You have to put your time. Medicine, I think, is a way of living. Is a way of life. It's not just, well, I'm going to do an exam and I'm going to make money. That's not the way it is. You can make money in many other different types by far more than medicine. You're wasting your time if you want to do medicine and make money. My kid, who is 17 years old, he makes more money than I do. And it's just like the way things are happening in US now. You know, you're interested into internet or things like that, you're going to make a lot more money than medicine. It's not like medicine is a good way of life. You always make good money in US. I'm not complaining about it, but if your only interest is making money, medicine is not the way to go. First of all, you're going to be studying for so many years before making money. Then if you do anything else, you're going to make much more money by that time. So it's not question of money alone. Obviously, it's good money, good life, and more importantly, anything happen in this country or any other country, you can go to any other country and you have the knowledge to take care of your patients, and nothing bad happens to you. Just the reality of it's not like internet or crypto that goes up and down. You know, you don't know what's happening the day tomorrow. You know, huh? He is into crypto actually, and he sells and buys things online. And, I was just making fun of him in the beginning. And I said, well, you have to go to university. But now I realize the money he makes is no joke. So I said, well, do whatever you want to do. If you want to go to university, good luck or no. But one thing for sure, if you don't go to university and something bad happens to you, I cannot help you because I'm not in business. If you go to university, you have some sort of a degree, I can always find some friends to give you a job at least down the road. But he's very happy, so he's buying a Lamborghini now. So, that like if you are 18 years old with that much money, I think you have fun. Now, it's different when you become 25, 26 years old. I don't know what happens to him, either in jail, who knows what happens. But I mean, for money, don't go into medicine in this country. I think you should enjoy it. I like it. I go to work every day and I'm enjoying it every day because I see patients, which is great. I do research, I do admin work. I think this combination and talking to patients every day and doing something for them every day is unique. Is a fantastic experience in life. All right, guys. If you don't have any other questions, I think that's all. We get together. Yes. That's the second time they're asking me today. In general, I think the way we choose a subspecialty is based on having good role models. So if you find somebody, and in medicine, it's very important the pedigree, where you go and where you're coming from. And if you have a good role model, and I said I went to US to work with Fred Coe, who's expert in the area of kidney stones. And you really have to work with some of these giants of medicine to realize that these are like great people, very, very smart people who can teach you not only medicine, but also how to live your life and how to approach problems. I think when you start your clinical rotation, you're going to find a number of very, very good role models. And some of them, I'm sure that you're going to get attracted to work with them. most people, I think, at your level, they don't know what they want to do. Maybe say, well, I'm going to be a plastic surgeon just because they make money. Or maybe you think, well, I'm going to just be an internist in a rural area. But you really don't know until you start your clinical rotations. Then you realize that what is good for you and what you like to do. But having a role model, that person makes a mentor for you for the rest of your life. That's very important to have a mentor in medicine. Yeah, I mean, I got hooked working with him. Yes. My second choice was going into surgery. Yeah. 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 Some things, cardiology I never liked too much. I thought it was like studying plumbing. That was not for me. All right, guys. Thank you so much. I appreciate this. Thanks.